Medical problems faced by athletes. Introduction to the module. As athletes undergo tremendous strain on their bodies due to the nature of physical sports, they tend to face a plethora of medical issues. Thus, this module aims to elaborate on various medical problems faced by athletes and also discuss how to prevent and treat such medical problems. Topics to be covered. Cardiovascular considerations. The athletic heart syndrome. Sudden death in exercise. Screening for sudden death. Dermatology. Mechanical injury. Environmental injury. Infectious injury. Dental. Epidemiology. Anatomy. Infection. Dental maintenance. Neurology. Headache. Treatment. Allergic diseases in athletes. Allergic rhinitis. Non-allergic rhinitis. Evaluation. Management. Medical therapy. Cardiovascular considerations. Enhanced cardiovascular health is one of the key benefits of most forms of consistent athletic endeavors throughout life. Regular physical activity promotes cardiovascular fitness and lowers the risk of disease. While there is generally a net cardiovascular benefit from athletic activity, there is also an increased cardiovascular risk for specific susceptible individuals. The athletic heart syndrome. Vigorous athletic training is associated with specific physiologic and structural cardiovascular change, which comprises what has been termed the athletic heart syndrome. These changes are non-pathologic and represent appropriate adaptations to physical training. It is important to remember that the adaptive structural and physiologic response of the normal athletic heart does not rule out an underlying pathologic condition. Sudden death in exercise. While there is a considerable net cardiovascular benefit to exercise, there is also a clear risk for susceptible individuals. The specific etiologies contributing to sudden cardiac death are most closely related to age. Generally, the dividing age is 35. This primarily stems from the observation that for sudden deaths over age 35, over 75% are associated with coronary artery disease. Screening for sudden death. Family history should include a specific inquiry for premature coronary artery disease, diabetes mellitus, hypertension, sudden death, syncope, and significant disability from cardiovascular disease in relatives younger than age 50. Personal past history should include specific inquiries on the detection of a heart murmur, diabetes mellitus, hypertension, smoking, or in the presence of HCM. Prolonged QT syndrome. Significant arrhythmias. Dermatology. Skin serves as a protective barrier against mechanical, environmental, and infective forces. Sport-specific dermatoses may incapacitate an athlete or expose a teammate to potential infections, impeding their performance or place them at risk for disqualification. Mechanical injury. Abrasions. Commonly known as rug burn, strawberries, or road rash, abrasions occur on artificial turf, floor mats, synthetic courts, and asphalt roads. Treatment consists of cleaning and debriding the tissue with warm, soapy water and applying a topical antibacterial ointment. Black toenail. The rapid deceleration of the forefoot against the shoe toe box may produce subungual hemorrhages of the first and second toenail beds. The condition occurs with greater frequency in sports requiring quick stops, such as tennis, skiing, hiking, and rock climbing. The hematoma can be drained by carefully boring a hole through the nail with an 18-gauge needle or electrocautery unit. Blisters. Repeated pressure or friction over bony prominences associated with excessive perspiration and improperly fitted equipment leads to the formation of blisters. Treat early with moleskin donuts and nylon foot stockings to decrease friction, talcum powder to absorb perspiration, and benzoin to harden the epidermis. Environmental injury. Sunburn. Exposure to ultraviolet or UVB, 290 to 320 nanometers. Light for 2 to 6 hours will produce mild erythema to intense blistering, edema, and pain. A rise in altitude from sea level to 5,000 feet intensifies sunlight by 20%. The ultraviolet, UVA, light range of 320 to 400 nanometers is 1,000-fold less burning to the skin than UVB. UVA is more penetrating and produces chronic damage to the skin. Miliaria. Miliaria rubra, or prickly heat, occurs in hot, humid summer environments. Fine, diffuse erythematous vesiculopapular rash develops over the occluded eccrine sweat glands. Application of hydrophilic ointments and mild topical corticosteroids can open the occluded ducts. Chilblain. Chilblain or pernio is the mildest form of cold injury and develops on the feet, hands, and face. Athletes participating in winter sports are initially unaware of the injury but later complain of reddish-blue patches that burn, itch, and may later develop blisters. The injured area should be rewarmed, massaged gently to increase circulation, and protected from further environmental exposure. Infectious injury. Furunculosis. Erythematous nodular abscesses found in the hairy areas of the axilla, buttocks, and groin. Highly contagious and known outbreaks have occurred in team sports, implicating close contact and poor hygiene practices. Acute treatment consists of warm compresses and a 10-day course of a cephalosporin, erythromycin, or penicillinase-resistant penicillin derivative. A prophylactic dose of rifampin, 600 mg for 10 days, has been utilized in resistant cases. Impetigo. Serasanguinous, honey-crusted pustules on an erythematous space. Beta-hemolytic streptococci more commonly produce impetigo, but staphylococcal species have been isolated from cultured wounds. Athletes participating in contact sports or swimming are highly contagious and should not participate in competition until all lesions have resolved. Tinea cruris. An erythematous, pruritic plaque with well-demarcated, scaly borders that extend to the groin, upper thighs, abdomen, and perineum but spares the scrotum. The scrotum is spared because of the fungistatic sebum produced by the scrotal skin. The appearance of an inflammatory, red rash with satellite lesions involving the scrotum is candidiasis and requires treatment with imidazole creams. Diagnosis can be confirmed by the presence of fungal hyphae on a KOH slide. Dental. There are many benefits to participating in athletic activities, such as enhanced physical fitness and the enjoyment from the competition. Sport, however, also increases the risk of sustaining an injury, especially injuries to the teeth and mouth. Sports medicine physicians are in an ideal position to facilitate early intervention to preserve dental health and promote proper preventative strategies. Epidemiology. An oral injury can be defined as dental avulsions, dental fractures, dental luxations, lacerations or contusions to the gum, cheeks, tongue, lips and jaw injuries. A concussion from a blow under the chin can also be included. Contact sports, such as basketball, hockey, and football, have a great risk of orofacial-related injuries. According to a study based on 159 injuries reported by pediatric dentists during a one-year period, the sports receiving the most orofacial injuries were baseball and biking, followed by hockey and basketball. Biking, despite not being a contact sport, carries a high risk of orofacial injury, as previously mentioned. According to the literature, boys are more likely than girls, 3 to 1, to sustain orofacial sports-related injuries. Parents often seem to be more likely to make their sons wear mouthguards than their daughters. Anatomy. The tooth is composed of 3 layers: enamel, dentin, and the pulp chamber. The enamel is the most external layer of the 3. Enamel protects the crown of the tooth because of its hardness and structure. The next layer is called the dentin. The dentin is softer than the enamel and has dentinal tubules that contain neurovascular structures. When dentin is exposed, it is very prone to decay. The internal structure of a tooth is the pulp. Infection. Pulpitis is when an inflamed pulp will become necrotic, causing inflammation around the apex of the tooth. The tooth will then have localized pain, swelling and sensitivity to percussion. Referral to the dentist for either a root canal or extraction is needed. Pain medication may be given, but antibiotics are not necessary. Patients with severe swelling in the head or neck with possible airway compromise often need hospitalization. These patients will need surgical drainage and 4 broad-spectrum antibiotics immediately. Prevention. A properly fitted mouthguard should be protective, comfortable, resilient, tear-resistant, odorless, tasteless, not bulky, cause minimal interference to speaking and breathing, and have excellent retention, fit, and sufficient thickness in critical areas. Boil and bite mouthguards are the most common on the market. The mouthguard is immersed in boiling water and formed in the mouth by fingers, tongue, and biting pressure. This mouthguard does not cover all the posterior teeth, decreasing the protective qualities and increasing concussion chance. Dental maintenance. It is important for athletes as well as the general public to have regular dental checkups. An initial comprehensive dental examination should be performed, including chief complaint, health history, intraoral and extraoral examination, and radiographs where applicable. Then, the dentist will recommend a recall schedule as needed, dictating by the evaluation. Dental professionals are advised to give these patients information about the problems that can occur with the jewelry. Tongue piercing can cause teeth fractures and also gingival stripping. Dental professionals should also inform patients that the jewelry should be removed before any contact sporting participation. Dentists can also screen patients who are using smokeless tobacco and inform them it is not a safe substitute for smoking. Neurology. Mild traumatic brain injury (MTBI), or concussion, is a common consequence of collisions, falls, and other forms of contact in sports. The rapid yet accurate determination of which athletes require immediate emergency room evaluation may be critical to an athlete's survival. The lack of participation in exercise and team sports by athletes with epilepsy is based largely on unfounded fears and misconceptions. Headache. The International Headache Society, IHS, provides an extensive classification system for headaches. While academically accurate, the provider on site is better served by a decision analysis tool that quickly distinguishes between those headaches that require minimal medical involvement and those that might require rapid evaluation and treatment. Serious headache requires immediate evaluation and treatment. It occurs with or without trauma and is associated with other neurologic symptoms to include mental status changes, nausea, vomiting, increased neck stiffness, or focal neurologic findings on examination. Concerning headache requires evaluation and treatment but not immediately. The patient meets the criteria for concussions but has none of the serious headache signs or symptoms. Benign headache required no further evaluation or treatment. Best described as a tension-type headache that occurs as a result of exertion or effort. Treatment. Treatment of benign exertional headaches includes the use of nonsteroidal anti-inflammatory medications either acutely or prophylactically. For athletes with effort migraine whose symptoms resolve abruptly, treatment is not indicated. For those athletes with prolonged debilitating symptoms, the use of classic migraine medications may allow for a faster return to activities. While treatment for weightlifters' headache may include rest, ice, and nonsteroidal anti-inflammatory, recurrent strain-type headaches warrant further neurologic evaluation to include computed tomography, CT, and/or magnetic resonance imaging, MRI, to rule out any underlying pathology as the headache source. Allergic diseases in athletes. Allergic rhinitis is the 5th most common chronic disease and the most prevalent in patients under 18 years of age. Urticaria and angioedema affect 20 to 30% of the population during their lifetime. Allergic rhinitis. Allergic rhinitis occurs when an individual develops IgE sensitization to aeroallergens. Inhalation of the aeroallergens leads to mast cell activation and release of histamine and other chemical mediators of inflammation. Common symptoms include rhinorrhea, postnasal drip, congestion, sneezing, cough, and pruritus of the nasal and soft palate. Patients may complain of generalized irritability and fatigue. Eye pruritus, injection, irritation, and watery discharge may indicate coexisting allergic conjunctivitis. Symptoms recur on exposure to any aeroallergen to which a patient is sensitized. Non-allergic rhinitis. The etiology of non-allergic rhinitis is unknown. The prominent complaint is nasal congestion. Nasal, eye and soft palate pruritus are usually absent. Symptoms are often perennial and triggered by strong odors or smoke. Evaluation. The history should focus on isolating an allergen exposure. A personal or family history of asthma, allergies, and eczema leads to a higher suspicion of allergic rhinitis. Physical examination will not distinguish between allergic and non-allergic rhinitis. Management. Allergen avoidance is essential in managing allergic rhinitis. 1. For dust mite allergy, use occlusive covers on the pillows, mattress, and box springs. Frequent washing of bed linens and blankets in hot water is helpful. Dehumidifiers and removing carpet may help. 2. Mold allergen can be difficult to control, but dehumidifiers and scrupulous cleaning can be beneficial. Medical therapy. Medical therapy is initiated in a stepwise fashion. Available medications include 1. Decongestants. 2. Oral antihistamines. 3. Topical antihistamines. 4. Cromolyn. 5. Corticosteroids. 6. Leukotriene receptor blockers. 7. Topical ipratropium bromide. Topical nasal decongestants are for short-term control of severe congestion. Their use should not exceed 3 days. If used for more than 5 to 7 days, they can cause severe rebound congestion and rhinorrhea. Summary. In this module, we have covered the following. Enhanced cardiovascular health is one of the key benefits of most forms of consistent athletic endeavors throughout life. Regular physical activity promotes cardiovascular fitness and lowers the risk of disease. Sports medicine physicians are in an ideal position to facilitate early intervention to preserve dental health and promote proper preventative strategies. It is important for athletes as well as the general public to have regular dental checkups. Allergic rhinitis is the 5th most common chronic disease and the most prevalent in patients under 18 years of age.